Good afternoon, and welcome to the last Child and Adolescent Psychiatry Grand Rounds of this academic year. I'm excited to introduce our speaker today, Dr. Nick Welsh. Dr. Welsh is a second-year Child and Adolescent Psychiatry Fellow at UCSF. Originally from Central Illinois, he graduated college from the University of Chicago with a degree in biological sciences. He then earned a Master's of Science in Biomedical Sciences from Rosalind Franklin University of Medicine and Science. He then attended Chicago Medical School, earning his MD, as well as a Master's of Science in Healthcare Administration. At Chicago Medical School, he was a member of the Gold Humanism Society and was given Dean's Award for outstanding service to the medical school. He completed 3 years of general adult psychiatry residency training at Dartmouth Hitchcock Medical Center, where he was awarded a Dartmouth School of Medicine Resident Teaching Award. He is currently finishing the second year of his Child and Adolescent Fellowship at UCSF. Our discussant today is Dr. Glowinski. She is the Robert Porter Distinguished Professor in Child and Adolescent Psychiatry and Behavioral Sciences Division Chief at UCSF, both Mission Bay and Oakland campuses. She also serves as the medical director for the Schwab Dyslexia and Cognitive Diversity Center. She is recognized nationally and internationally as a medical education expert with a versatile and broad foundation as a clinician scientist. She has led or contributed to several projects related to community child mental health, including projects on the genetic epidemiology of youth suicide and suicidality, depression, bipolar disorder, and social reciprocity. Join me in welcoming Dr. Welsh, who will take it from here.
My name is Nick Welsh. I'm a second year Child and Adolescent Psychiatry Fellow here at UCSF, and I'm excited to talk to you all today about the placebo effect in child psychiatry and whether or not it's a friend or a foe, which we'll get into over here. And I'm pleased to have Dr. Glowinski join me for this. Dr. Glowinski, I feel like she's been my supervisor in my flock clinic for the past year and has been really good at knowing both like the limitations of medications and information about medications and what makes them effective, but then also can really relate with patients and from like this dynamic perspective. And I thought would be a really good discussant for this. So thank you, Dr. Glowinski, for joining. Let's see here. Okay, so objectives of today's talk. Well, first, I have no relevant disclosures to disclose. In terms of objectives for today, I want to review the concept of the placebo as well as the nocebo and how it relates to child and adolescent psychiatry. We'll review mediating and moderating factors that influence the placebo effect, and then discuss ethical implications of the placebo and nocebo effect in the pediatric population. And then finally, we're going to hopefully gain an understanding of ways that we can leverage the placebo to increase the placebo response and hopefully mitigate the nocebo response, which we'll also get into. This whole thing kind of came up to me when with a patient's case, which I'll discuss here. So this is Ashley. Ashley's a 14-year-old female who has major depressive disorder, generalized anxiety disorder, anorexia nervosa, and migraines. She was referred to the UCSF Department of Child Psychiatry by her PCP for recommendations around further medication treatment. She was taking at the time of intake 40 milligrams of Prozac daily and had been on that for several weeks. She had also already trialed a trial of Lexapro, got up to a max dose of 20 milligrams and was on that for about 2 or 3 months, which wasn't effective. So then they transitioned to Prozac. And she was receiving CBT therapy for depression and anxiety with some effect, but overall was still struggling. She endorsed a lot of irritability, hopelessness, feelings of worthlessness, low energy, passive suicidal ideation, issues with concentration, low appetite. And so just a lot of symptoms of depression. At the first appointment, when we first met, she had said that the Prozac that she was taking was moderately helpful. Her parents felt that it was much more helpful than Ashley was presenting. But Ashley did feel like it was moderately helpful, just not as effective as parents thought it was. So at that appointment, we talked about increasing the Prozac to a higher dose to try and maximize the medication. And so we had planned to go up to 60 milligrams. And so that was our first appointment. The next appointment, after we checked in around how the increase in the Prozac went, she had actually kind of changed how she felt about Prozac. She felt like the Prozac was never effective, and it certainly wasn't effective now. It wasn't associated with any side effects, but she was at the second appointment, was very interested in wanting to start Abilify or Lamictal. She had one of her good friends from school, who was a similar age, was admitted to a psychiatric hospital and was started on Abilify and Lamictal while she was there. And it seemed to have had some benefit to it. And so Ashley was pretty dead set on needing to be on Lamictal and Abilify in order to feel better. And so this got me thinking, like, how much of this is like the Prozac is just never going to work now because Ashley doesn't really expect it to work and expects these other medications to work. And then conversely, like, would it make sense then to prescribe Lamictal and Abilify, which may have heavier side effect burdens than something else that we might generally think to go to next? But if she has more buy-in for that and has more expectations, would that be worth then giving that a try rather than something else? And so this got my gears turning about this and trying to think about it and doing some research, doing a literature review to see if there was anything about this. So that's where we'll start. In terms of better understanding the placebo effect, I think it's important to review a little bit of the history. So it's actually, the word placebo comes from a mistranslated psalm. It was supposed to be, I shall walk before the Lord, to I shall please the Lord. And that was back in the 1300s in a translation from like a Hebrew text to English. And that was sort of the first use of the word placebo, and ingrained in this concept of wanting this aspect of pleasing, this aspect of like the placebo is something that should please. It wasn't until 1772 that a British physician, Will Cullen, wrote some articles about the placebo. Specifically, he wrote about using lower doses of different herbs to placate and act as a placebo to please a patient, despite the fact that he didn't think that they would actually have a meaningful effect in terms of like the functionality of it. But he would still see that patients did get better with it. And so that was the first sort of concept of using a placebo. And then in 1784, Benjamin Franklin actually turns up with Franz Anton Mesmer. And so this gets into a little bit of mesmerism, which I just thought was interesting. So Franz Anton Mesmer, he devised this therapy called animal magnetism, which uses these pretty ornate rituals that one person would do to someone else that Mesmer would do to a patient. And these rituals like hand waving and different things like that would influence invisible fluid channels throughout the patient and then therefore release different blockages and then improve their symptoms. And this animal magnetism was actually catching on in terms of popularity throughout Europe and even into the US. And so in 1784, King Louis XVI appointed Benjamin Franklin and Antoine Lavoisier to investigate these claims about animal magnetism. And this was actually the first recorded use of a placebo or sham intervention. What Benjamin Franklin and Antoine Lavoisier did is they had someone who didn't practice animal magnetism step outside of a room, and then inside the room was a patient who was having seizures. And the person performing the animal magnetism from outside the room did some things, and the patient then got better, despite actually the patient not receiving any actual treatment. There was no animal magnetism that was performed, yet the patient still improved. And this was the first recorded use of some sham intervention or sham animal magnetism to disprove disprove a treatment effect. Then this sort of outrageous picture represents Perkins tractors. These Perkins tractors were these metal rods that someone had invented that were made of these different alloys that if you implanted them into a patient, they were supposed to perform some sort of improvement, some sort of treatment, and that would then improve their symptoms. And so John Haygarth did the first like a placebo control of this, where he implanted, rather than using these metal rods, he used these wooden rods without telling the patient, and then patients also got better. So this was just another example of placebo as a control. Then in 1863, we have Austin Flint using a low dose of an injection to treat rheumatic fever as a placebo control. And then in 1935, Henry Gold was the first one was the first person to do a double-blinded placebo-controlled trial looking specifically at xanthines for angina pectoris. And so that sort of established double-blind placebo-controlled trials as being sort of like the gold standard. Then in 1955, we have Henry Beecher, and Dr. Beecher published a paper called The Powerful Placebo in 1955. And that was the first time that someone had sort of pooled together different studies. He pooled about 19 different studies together to look at the effect sizes of placebo compared to active interventions across like many different treatments. And he found that on average, there was around a 35% placebo response rate. And that this was a meaningful amount of improvement, and therefore this could be something more than just controlling. He was interested in like what this placebo was actually doing that was seeming to improve symptoms despite there actually being an inert substance used. So in terms of the placebo, what are we talking about? Well, when we say placebo, that's referring to typically a sham treatment or inert substance, usually a sugar pill or a saline infusion. And this is specifically referring to like in an experimental situation. The placebo effect is any improvement in a symptom after receiving a placebo. And that's different than the placebo response, which is a little confusing. But the placebo response is the psychophysiologic response to an intervention, which is not due to the inherent intervention in and of itself. I've got some graphs to sort of show this because it is a little, I found it a little confusing at first. So here we can see that, so we've got three different lines here. This, on the bottom, we have time, and we have no treatment with the placebo, and then the active treatment, which includes some sort of active drug. The placebo effect is just the difference between no treatment and the outcomes in someone who receives the placebo. But there's more to it than just this placebo effect. There's also, for the placebo response, it includes contextual effects, which include things like natural history, regression to the mean, which we can get into a little bit later. So just to emphasize that the placebo effect is more so just the specific improvement due to a placebo, whereas the placebo response is the placebo effect plus this extra stuff that's happening. Here's another graphical representation. Here we see that there's no treatment, then we have the outcome when we add a placebo to it, and then this is when we have an active treatment. And so the placebo effect is this area right here, but the placebo response would be larger. This is another pie chart that sort of looks at this and looks at other things that influence the placebo response. And so when we look at this, we can see that the placebo response really is found to be due to three main areas. One is conditioning, two is expectation, and then the third would be doctor-patient communication or interactions. And then there's these other things that are happening that can sort of confound or look like the placebo response, but that are actually possibly like statistical anomalies or different biases or other non-specific aspects to the intervention that's being measured. So specifically, when we're talking about these errors and biases in measurements, the two that come up the most often are regression to the mean and the Hawthorne effect. So regression to the mean is looking at when you're taking data and recording values of different symptoms. So let's say like a PHQ-9. Oftentimes, if you have a high PHQ-9 number, just the nature of the way things work is the next time you take a measurement, it likely won't be that high. And so that next measurement will come out a little bit lower, and it could actually look like positive treatment effect when it actually is just due to the fact that the initial measurement was a high measurement. And this is important, specifically in child psychiatry, because there's some evidence that this is contributes larger to what could look like a placebo response. And this is because there's some evidence that parents will often exaggerate symptoms in order to get in a clinical trial. And so then once the patient is in a clinical trial and they've had these exaggerated symptoms from a starting point, the next measurement will likely be improved just because of this regression to the mean. The Hawthorne effect is a different sort of effect, and that's where people change their behaviors if they know that they're being observed. And so it's not that, receiving a placebo or even receiving an active medication is necessarily changing things, but it's the fact that they're being observed in this clinical environment, this experimental environment, that can change the effect and change outcomes and make it look like treatment is happening when it's actually due to a different effect. And I think this is a good example of how there's this difference and sort of tension when we're talking about the placebo effect in child psychiatry, specifically between researchers and then clinicians. Not that they can't overlap, obviously, but in research, the goal is to minimize the placebo and sort of make sure it is as small as possible. Whereas in the clinical environment, even if we're not necessarily prescribing an actual placebo inert medication, we can still take advantage of some of these like non-specific benefits that come along with placebo treatments and use them in our active medications that we prescribe. And so that's what I wanted to think about and think about in terms of the case of Ashley and trying to figure out if how to go about choosing what medication to use for her. In terms of placebo response rates in children versus adults, this is, I think, the one consistent moderator. There's like some other moderators that sometimes show as being a moderator in some studies and not in others, but age is pretty consistent across the board that younger patients generally have larger placebo responses. So we can see depression is actually has one of the highest rates of placebo responses, and 54% of placebo, there's a 54% placebo response in children less than 12, 45% in children over 12, and then around 35% in adults. In ADHD, it's around 20 to 30% of a placebo response in children versus around 10% in adults. And this isn't just something that's happening in psychiatry, it's also happening in other areas of medicine, often in neurology. That's where they also see high placebo response rates. So for example, migraine headache has a 48% placebo response compared to just 28% in adults. And epilepsy, also 19% placebo response compared to 10% in adults. And specifically there was actually no significant difference in medication efficacy, but that there was this significant difference in the placebo response rates. This is a different chart that's looking at it, which again is showing similar findings. The third row, the pooled is just combining children and adolescents together. And we can see that children, adolescents, and the pooled results all have higher placebo response rates compared to adults. And specifically, the placebo response rate is highest in depression. And then second would be non-OCD related anxiety disorders, and then OCD related anxiety disorder. OCD would have a lower placebo response rate, but it's still pretty high, as you can see. So I guess that sort of like the question is then, why is it that children are having these higher placebo response rates? And this gets into a little bit about the mechanisms of what's going on with the placebo response. In adults, we mostly think it's due to expectancy effects and conditioning. So like classical or Pavlovian conditioning. But in children, it's been harder to sort out and tease apart. In terms of like the neuroscientific mechanisms of this, there's lots of things that are implicated, including dopamine, opioids, serotonin pathways, and the endocannabinoid systems. But the direct mechanisms still remain a little unclear. What are some moderators of the placebo response? So this is a theme that I think will come up time and time again, is that most of the research is actually completed in the adult population. So we're limited in what we can report on. But as I mentioned earlier, age is really the one well-established moderator of the placebo effect in children. They looked at personality factors, specifically in adults, and they haven't looked at this in children yet, but in adults, there's some suggestion that high suggestibility, dispositional optimism, and having an external locus of control influences the placebo response rate. But again, even in adults, this is not consistent across studies. So in looking at the placebo response rates in children, why are we seeing this higher placebo response rate? One would think that child expectancy would have a large effect here. As I mentioned before, expectancy and then the classical conditioning are typically two of the reasons that people attribute the placebo response to. But in terms of in child psychiatry, it seems that expectancy responses play a minor role. So in depression, it seems that it has only a small effect and impact on the placebo effect. And they're not really sure why it's not as large as adults. They speculate that there's other things going on, like there's more frequent contact with study investigators. But the interesting thing here is too, in this recent meta-analysis from 2019, looking at depression and placebo response rates in children and adolescents, it was only for teens that they had, there was a relationship between placebo response, and younger children didn't have a placebo response relationship with more frequent contact with study investigators. But overall, they think that children, placebos and probabilities and experiments are kind of complex cognitive concepts to wrap your mind around. And so it's possible that children and teens don't necessarily have the same expectations or hopes about clinical trials or having being involved in something like that to have a higher expectancy effect. And then also ADHD, we see that the stimulant medications have significant positive effects on multiple symptom domains in ADHD. And yet most studies show that patients don't have any expectancy as to whether or not a medication will be helpful. And even if a medication is helpful, they're very unlikely to attribute any of the improvement or even things worsening to the medication. So it's not coming from child expectancy effects. Where is this increased placebo response coming from? And one thought is this concept of placebo by proxy. So this was coined by Drs. Berlotti and Kapchuk in 2011. And this is essentially recognizing that the placebo effect doesn't happen in a vacuum, and that there's a lot of other social interactions and dynamics that can contribute to the placebo response, specifically with parents, but also with caregivers and other people who are involved in the child's life. And so it's this effect that when a patient is receiving care or connected to care, there's typically a placebo response, or placebo effect by proxy, where the proxy, the parent, the caregiver, whoever, will feel better about the child being in treatment. And then that might have different placebo effects. And so there's a couple of different proposed mechanisms looking at this. And so the four that they've looked at most consistently are expectancy effects on children's behaviors and cognitions, changes in caregiver perception, changes in caregiver behavior, and then also the conditioning. And to look at this, specifically the parental expectancy effects, I wanted to look at an older study that actually isn't really using placebo, but it is an interesting study looking at expectancy in just a slightly different way. So this was back in the early 90s. They took a group of about 35 children, boys who had ADHD, who had been classified as sugar sensitive, that their parents had said that they have bad responses to sugar and it can kind of make them act very hyperactive. And so for the study, they took half of the patients and told those parents that the child had drank a sugary drink, and that they would then hang out with their child and be observed and recorded before going home. And then the other half of the parents and children, they said that they didn't receive a sugary drink, and that they would also just observe their behaviors and interactions before going home. And but the difference was no one actually received a sugary drink. None of the kids received a sugary drink. It's just that half of the parents thought that their child did receive the sugary drink. And so parents who thought their child had sugar rated their child as more hyperactive, more defiant. They also hovered more. They were just closer, often like watching over them and like interjecting. And then were more critical and like giving verbal criticisms also. This is obviously sort of counter to what we would think of in terms of like behavioral management of ADHD, right? It's about increasing attending time and focusing on the bond with a parent, and so that there is more positive interactions. The interesting thing also was that they had actimeters on the wrists and ankle of the children, and the children who the parents rated as more hyperactive were actually less hyperactive than the other children. It was this, but still the parents perceived that they were more hyperactive, more disruptive and oppositional and defiant. And so this, then you can see how it sort of creates this self-fulfilling prophecy in a way where if a parent is sort of hovering over their kid who has ADHD, you can expect that might not go over all that well. So this is just looking a little bit at the expectancy effects and conceptualizing them in a different way. But we see that the parental expectancy effects do have effects on placebo in studies in different ways, and that they both will perceive the child is getting better and also change the way they act with the child, which could then change the outcomes of the treatment. So in terms of maximizing the placebo's additive effects, again, there hasn't been a lot of research that has looked into this specifically in child and adolescent psychiatry, but they have looked at it in adults. And here's what they suggest is to communicate with patient-centered language and describe the basic mechanisms of the treatment in a way that the patient and their proxies can understand. And it's important to provide information about why the treatment should be effective so you can communicate realistic optimism and hope. So making sure that patients understand, you're prescribing a medication for this reason because you think that it could be helpful. It's been also shown to be important to use an emotionally warm and empathetic style. They think that this can enhance the placebo's additive effects by improving anxiety. And I think, but most importantly, in child and adolescent psychiatry, I think the best way to maximize the placebo effect is to involve the proxies. So involve the parents, the caregivers. It can even work through teachers have a proxy effect, both a placebo by proxy and a nocebo by proxy effect, although it's weaker than parents, placebo by proxy effect. They also have found that it can happen and occur with other providers. So For example, if I'm taking care of a patient and my patient just establishes with a therapist, there's this placebo by proxy where I feel relieved that they have this additional care and therefore may be more likely to see benefit or ascribe things in a positive way than I would had they not been connected to another therapist. So that's a little bit about the placebo effect. I think it's important to also talk about the nocebo, which is sort of described as the darker cousin of the placebo. And it's basically just the flip side. It's this phenomenon where the context, rather than the actual content of the medication or placebo tablet or whatever it is, can produce unpleasant side effects despite being an inert substance. And it's estimated to be responsible for anywhere from like 40 to 100% of side effects in some pharmaceutical trials. Again, here we see that it's less well defined in the literature and that mechanisms and contributors to this are less well understood. And it also seems to be more like a wider impact compared to adults and children. The way they think that the nocebo response is happening is the nocebo effect is happening is through the informed consent process. And that's where we will instill these negative expectancies around side effects. And then that causes increased anticipatory anxiety in the patient, which they then have increased attention towards their internal bodily state, and then are more likely to observe and feel side effects. And so there's this tension here in terms of the ethics, right? So on one hand, non-maleficence is like the number one goal is to do no harm. And so by telling a patient about every side effect that they could have from like the printout, I'm increasing the probability that they will have those side effects. But then this like non-maleficence is in conflict with patient autonomy, where it's the patient's right to know what they are being treated with, all the side effects that they could be having, so they can make the best informed decision for themselves. Yet that's at conflict with this idea of the nocebo. So how do we reconcile this? Wells is a bioethicist who talks about this concept of contextualized informed consent. And that's where we tailor our side effect information based on contextual factors. And there's the three contextual factors include the type of side effect, patient factors, and then diagnostic severity. In terms of the type of side effect, they caution that non-specific symptoms, so things like headache, nausea, decreased appetite, fatigue, all of these are, by naming them and warning patients of these side effects, are much more likely to happen. The non-specific side effects are the most susceptible, likely due to just the increased background prevalence in day-to-day life. And so rather than warning necessarily about these side effects, they recommend having the patient reach out and contact you if they're having any different side effects or changes in the side effect, rather than like listing all of the potential non-specific side effects they could have. And then if they do call when new symptoms arise, then you can have a conversation about what those symptoms are and think if it could be due to the medication or if it could be due to a nocebo response. Then there's these patient factors. And these include the tendency to somaticize, having a history of adverse offense, and then also having non-specific symptoms pretty frequently at baseline. All of those things can increase the nocebo effects. So what they argue here is to focus more on drug-specific side effects that are relevant, specific, the ones that we're most concerned about. So things like tremor with lithium or a rash with amygdala, rather than going through an exhaustive list or even like a moderately exhaustive list of potential side effects. And then finally, the last thing to consider is diagnostic severity, because they argue that in milder cases, any side effect could, outweigh the benefit. And so in milder cases, it might be worth going into more depth about side effects so patients don't end up feeling worse from a side effect than they do with whatever disorder they're trying to treat or whatever symptoms they're trying to improve. How do we mitigate the nocebo effect? one area of research is focused a lot in how we frame things and how we frame our side effects. And so positive framing has been found to be much more beneficial for improving or limiting the nocebo response rate, nocebo effect. So instead of saying 30% of patients experience headaches, you say 70% of patients don't experience headaches. And the reason they think that this could be helpful for reducing the nocebo effect is by decreasing the anticipatory anxiety. And then if a patient then suddenly does develop a side effect, explore what they think the side effect is about. And there's evidence that explaining the nocebo effect, if you think that it's a genuine nocebo effect, or it could actually help with the symptom. So both this positive framing and then also like providing some psychoeducation around the nocebo effect can be helpful in mitigating the nocebo effect. And then I thought I wanted to talk a little bit about this concept of open label placebos, which is only recently been coming out. And so this was done by Dr. Nurko in 2022. And this was 30 patients who had IBS or functional abdominal pain. And it was a crossover design you can see in that figure. And that they were told that while they were on the open label placebo, they were told that they were taking a sugar pill that didn't have any medication in it, but that this has been found to help adults with abdominal pain. And so in terms of the results, they found statistically lower pain scores during the open label placebo with an effect size of around 0.16. 21 out of 30 patients reported that they had they had higher pain scores during the with the control. That's the typo. And they also used fewer rescue medications during the open label placebo. So they only used 2 tablets of pycosamine versus 3.8. And interestingly, they didn't find any association with parental or patient expectations. But this is important in that it shows that placebos don't need to be covert or deceptive in order to work. That even when patients and parents know that they're taking a placebo, they can still have some benefit. And this is one example of using an open label placebo in ADHD in a bit of a different way. So this was Sandler in 2010, and there were 99 children with ADHD. And so this was an 8-week study. The first 4 weeks was a dose optimizing stage where they started with a low dose, then increased to a moderate dose, and then evaluated for side effects to get the patients on an effective dose of mixed amphetamine salts. And then once they were on that effective dose for another 2 weeks, there were 3 ways in which they were randomized. Some people were continued at the full dose to receive the full dose for all 8 weeks. A third were randomized to a reduced dose where they reduced the dose for the second 4 weeks at 50%. And then this third group they reduced the dose by 50%, like the reduced dose group, but then they also had this placebo that they added to it and that they took at the same time as the reduced dose. Then the observers, the experimenters tracked parent rating scales 3 times a week, teacher rating scales twice a week, and then had conversations with patients and parents that the placebo that they were taking in this reduced dose placebo group was inert, and that we're doing this experiment to see if it could be an effective dose extender. What they found was that there was significant increases in symptoms in the reduced dose group, but that there weren't those same increased symptoms in the reduced dose placebo group. And that's this top little, this circle. The circle down here is the reduced group placebo group, and it's equivalent to the full dose group. Whereas this group up here shows that there's a higher ADHD symptom scores after week 4 when the switch was made, specifically in parents' scores of their IWP scores. And so this shows that the placebo was, at least in terms of looking at it through a parent's lens, didn't change from allowed it to stay effective at a lower dose. Interestingly, teachers were not aware that what group the child was assigned to. And so they weren't blinded, and they showed that there were worsening symptoms in the reduced group placebo that were consistent and similar to the reduced group without the placebo. The experimenters thought that, maybe this is due to, they had a hard time obtaining teacher reports. And that also there have been lower placebo response rates when you talk with teachers about patients too, so that was contributing as well. And then they wondered if there would be any change in like the side effect profile of patients who do go down on the dose, the reduced dose, who don't take the placebo. And what they actually found was that they had more ADHD symptoms in the reduced dose without the placebo. So this higher one up here. And they speculated that is because they just had more ADHD symptoms, and things like sadness, tearfulness, stomachache, tiredness, sleepiness. Those are all questions that get asked on the objective measure of like side effects that were sort of confounding the results. So returning back to the case vignette, Ashley continued to feel that the Prozac was not effective even at the higher dose of 60 milligrams. She continued to want to feel like the Abilify and Lamictal would be a better choice for her, and wanted to give that a try. But there's concerns about the side effects of both Lamictal and Abilify, and like questionable evidence basis for this. And so I leverage some of the things that we've talked about here in the following ways. I mean, I really did a lot of reflective listening and just heard her concerns and validated, her frustration with not feeling better despite having two pretty lengthy trials of antidepressants. And then we talked a lot about what the evidence is that we have in treating treatment-resistant depression in children and teens. And talked about Effexor and decided to start Effexor. And in talking about Effexor, I highlighted the fact that this has a slightly different mechanism of action compared to the regular SSRIs that Ashley had already tried. And so it's possible that there may be an additional benefit of the medication having a slightly different mechanism of action. Then in terms of minimizing the nocebo, we didn't go into a ton about non-specific side effects. She already struggles with migraines and had like non-specific symptoms sort of as part of the neurovegetative symptoms of depression already. So we didn't focus much there, but we did review important drug safety concerns that are like specific to Effexor. So that's like increased suicidal ideation and the risk of hypomania. That we made the switch maybe, I think it was about a year ago. And she's been doing really well. She's been feeling like the Effexor has been helpful, isn't associated with a lot of side effects, and hasn't been asking to start Abilify and Lamictal, and has been feeling like her mood is much improved. So I think this was a useful case to sort of understand how we can think about these different concepts. So in summary, here are some take-home points. The placebo response is a valid psychobiological effect that happens across many different conditions. And there's many different reasons that the placebo response happens. In large part, especially in child and adolescent psychiatry, the placebo response is both initiated and maintained by the psychosocial context. So the proxies in the child's life. Interestingly, you don't need to actually give a placebo to generate a placebo response. So the placebo response can augment a therapeutic encounter, sort of like what we just talked about with Ashley, using these additional ways to enhance expectancy to hopefully improve these non-specific effects that contribute to increased response. More recent research has showed that non-deceptive placebo administration can generate a meaningful placebo response, and placebo effects can be augmented with non-specific factors. And then finally, we can limit nocebo effects with contextualized informed consent and making sure we understand different factors that could characterize whether or not we should go into more extensive conversation around side effects or stay at a maybe more surface level discussion of it, depending on these different factors. And then here are some references. No, I think that's it. I think that covered everything. So if Dr. Polinski has anything you wanted to add or chime in with, that'd be great.
Well, thank you so much, Nick, for your very interesting presentation and also for giving me an opportunity to make some comments. I really appreciated working with you as well. And think that what is beautiful about your presentation is that it really sits where I think we have a strength that we don't always talk about in psychiatry and psychological sciences, which really relates to practicing in ways that are both as physicians, so sort of like following the medical model, but also understanding factors, cognitive, social, psychological, emotional factors that influence our patients, our families, and ourselves. So sort of thinking about the greater context of what you're talking about, which is a kind of thoughtful prescribing, getting away from some dichotomies that I think we've all encountered, dichotomies that are sometimes related to identity, to professionalism, guildism, etc. But so this sort of idea that psychiatrists are prescribers, and then we have other mental health professionals who are therapists. So I actually was invited not too long ago to contribute to a volume on prescribing. And I'm going to show, for greater context, if I can share my screen, actually. Let's see, how does it work? So there we go, share screen. So I'm going to show a table which I came up with a couple of years ago with a former trainee called Max Rosen, who's now the medical director at Welsh in our clinic. And so this was, let's see, how do I share that? Okay, so this is a table talking about what we do in a brief pharmacotherapy visit that other people may call med check, which I don't want these visits to be called med checks because they suggest a simplicity that really doesn't exist in our practice. And so related to what you talked about, I think it's important to remind everybody that there is science behind things that don't have to do with medicine that we do when we prescribe. So for example, this idea, I'm going to sort of walk you down, that you can see in the first row that you need to tend to rapport. You really need to spend time establishing a bridge between you and the family, and a bridge of trust and a bridge of good communication is evidence-based. It's not something that we're just teaching for the sake of teaching it for nostalgic reasons. It is truly evidence-based. The idea that the illnesses that we treat, so this is going down the illnesses that we treat or the disorders that we address, are really usually determined by a combination of genetic and environmental factors, a lot of which may not be under our control, but a lot of which, if we know the history of the patient and the family, appear to follow certain patterns, and that it's important to assess what these environmental influences are when they visit with you. It's important to provide counseling that is not just, let's go up or down on your effexor. And it's important to look at factors of adherence, so that's also evidence-based, to have conversations about why people are liking or not liking their medications, et cetera, et cetera. So I'm just sharing this briefly to highlight that the importance of the discussion that you're having is that you're sort of saying, are there things that we do, maybe inadvertently, that we do inadvertently by sometimes creating conditions that make it particularly possible for patients to benefit from our treatments? And so the answer to that is a resounding yes. We even know from multiple studies that the probability that somebody who is given a prescription is going to fill this prescription in a pharmacy is extremely low. So even before talking about placebo and nocebo, we need to sort of talk about the importance to prescribe with a vision that includes maximizing adherence and also minimizing the side effects that you're talking about. So I chuckled when you were talking about this sort of opposition, in a sense, between the patient's autonomy and obviously the potential side effects of having an anxious person read the entire list of side effects associated with some of our medications. And it also made me think about the fact that some of the things we don't talk enough about, also related to prescribing and our practice, is this idea of what is the assent process, right, for somebody who is not yet at the age of consent for a medication or for any part of what we do, and whether we're spending enough time sort of thinking developmentally about the amount of information that each child needs and at what level. And so the way that I sort of assent kids related to what you were talking about is, I'll just say something like, are you the kind of kid who is going to get a cold if you hear, that other people, so I sort of get a sense of the suggestibility and then create a consensus with the family. Like everybody will be like, oh yeah, he's super suggestible. And then we will agree, everybody will agree that it's maybe better if we don't give the long list of side effects to the kid, but it's a group decision. It doesn't address what you're talking about, which is really important in child mental health, which you're talking about and which we all encounter, and we don't always know basically how to approach it conversationally, is the expectancy effects that parents can have in both good and bad ways regarding the treatment. And I don't know what other people think, but I know that certainly practically, if you avoid tackling these things, they come back to haunt us. Like so that it's better to have honest conversations with family about patterns that you think you're seeing vis-a-vis reactions to the medicine or anxieties about the medicine, rather than sort of hope that starting another medicine is just going to fix those problems. So what I really like about your case is that essentially you used evidence that you did for your presentation to suggest an approach. You know that it's not exactly evidence-based, it's more like evidence-suggested, but you used it to guide you to have conversations with your patient that were more respectful, more sort of joint decision-making kind of conversations, which are, by the way, evidence-based good. And that the result is good. And obviously, is the result good in part because you took this approach or because the medicine is better for this patient? It's probably a little bit of both if we had to make a bet, right? But it's important to highlight that the part where you didn't just think about what medicine is going to be better, but you thought about how can I prescribe better, is really something that we need to applaud and also think about teaching even more to our trainees. So I think I'm going to stop here to give other people time to comment and ask questions, but these were my comments. I have a lot more, but I don't want to eat the whole time with my comments. So thank you, Nick, very much. And I see we have a lot of comments.
Yeah. Thank you so much. I can, Dr. Blinsky, if you want to man the chat, you can do it too, but I'm happy to. But I just want to say what a wonderful talk and discussion. This is something I think a lot about, but not in an evidence-based way, I think. And so I loved the approach of kind of dissecting everything about the placebo response and all the things that go into it. I honestly didn't think about it in that way. I think about it as the art of psychiatry or how we do things, but I think it's a really thoughtful way to approach this. So let me take a look here. Starting with, why doesn't Lawrence Diller, you have a lot to say in the chat. Do you mind unmuting and voicing this question? Because it's a nice one.
It's just a comment. I've been around for a long time, and I always love the sugar study, which points to the power of attribution. You know, exactly opposite of what the investigators are expecting happened. And but the other thing I want to say was, in my experience, and there's some data that the children tend to claim success to themselves in ADHD medicine land, okay? But they attribute their failures to the medicine's not working. And I think that makes sense within the context of self-image, et cetera, et cetera.
No,
Any comment there? I don't know.
No. That's a really good point that that it's the attribution depends on the context of what we're attributing something to. Yeah. Thank you.
There's also a question here about specific cultural groups that might augment the influence of the placebo effect or response.
Yeah, that's a good question that Ning asked. There has been like some research like looking into this that I didn't dive into. And in fact, the research was showing that there's like not enough research about it, that there's like what we don't know. There's like quite a bit that we actually don't know about it, but that there's likely aspects of like racism and homophobia and things like that impact like structural racism and things like that impact the placebo response, as well as like the research that gets done into this.
It's a really good question because I don't mean this to be provocative. Some people may not agree, but like a lot of people would say that homeopathy is sort of a practice that probably physically doesn't have an impact, but has a big impact psychologically. So I do think that it's very possible that there are big cultural differences, but like Nick says, not well studied. We do encounter clinically sometimes people who are just like, I come from a culture where it's considered completely abnormal to take medications for my mental health. So I think this goes back to Nick's presentation. It's really important to not ignore that and go ahead. You have to work that through, but whether there is a way of identifying people in advance as potentially needing more work in these areas, I don't know that we know that.
Before time, I probably don't have time for this last one about remission times between placebo and drug. If there's anything in the last minute. Just about data on differences, probably not time-wise.
Sorry, I'm just responding. Yeah, there probably isn't a time. I was just curious about it because it's such a really interesting data. There's really interesting data there. I was just wondering if there had been anything done on that, if there was any data on that. But it's okay.
Yeah. I didn't come across any, but that doesn't mean that, yeah. No, but it is, interesting.
I think it's just one of the many things that we could talk for a long time about.
Sure.
But I want to thank you again, Nick and Dr. Glowinski, for this really, really great talk to end our series. And we'll pick up again, I think, in a few weeks. And I hope you all have a good rest of your Wednesday afternoon.
Thank you. Thanks, everyone.